2. So learning objectives for this material, we are going to be able to describe common health problems of middle and older adults, describe nursing interventions to promote health for middle and older adults, and identify healthcare needs of older adults in terms of their chronic illnesses, any kind of accidental injuries, and accurate care needs. So the older person is a person older than 65 years of age. We classify them as young old, middle old, and then old old. So young old is 60 to 74. Middle old is 75 to 84. And then old old is 85 and older. Based on recent studies, it's estimated that 10% of all adults that are age 60 and older who live in a community are abused. This is a very, very vulnerable population in many ways. And then of those 10% that are usually abused, the adult children and spouses are the most likely perpetrators. So these are important things for you to look at when you are taking care of this population of people and when they come in and you want to see how they're being cared for. So you're going to look at their skin and see if they have a lot of pressure sores, or their skin is broken down, or do they appear malnourished. And sometimes it's not that the family intentionally hurts them or tries not to take care of them, but sometimes this can be a sign of caregiver strain. Sometimes it's just hard for them to take care of them. Maybe they don't have the means to take care of them as well as they'd like to. Maybe physically they can't take care of them as well as they would like to, but their intent, it comes from a good place. They're trying to take care of them, but they just don't know how, or they just don't have everything that they need to be able to do so successfully. So we kind of have to advocate for these people and make sure that they're getting the proper care and make sure that we don't, suspect anything fishy going on when they come in based upon their assessment findings. All right, so one of the issues that we see with older adults is dysphagia. Some of them have difficulty swallowing or an inability to swallow. This could be from a number of reasons. It could just be that maybe they have dentures, or maybe they need dentures and they can't afford dentures, or maybe they've had a stroke and they have some residuals from that. There is an increased risk of aspiration with any patient that has difficulty swallowing or has an inability to swallow. Instead of it going down the esophagus like it should, it ends up in the lungs and then it sits down there and it causes pneumonia. So we call that aspiration pneumonia. So we want to take careful time to educate our patients and make sure that we are promoting things that will keep them from developing aspiration pneumonia. So we want to encourage them not to lay down after they have meals. We want to encourage them to stay upright for as long as they can. If we think they're having difficulty, we can thicken their liquids. We can talk to nutrition and have them come in and do a swallow eval on them. We always usually on all the units have thickened packets of thickener that we can add to their drinks to help it to make it easier for them to drink. If they do have trouble swallowing, we don't want them to use straws. That increases their risk of choking. And then we want to always tell our patient to tuck in their chin when they're swallowing. This will help keep that liquid going down where it's supposed to. And usually if your patient is an aspiration risk, you will have signs on the unit that you'll pull from their nurse's station that, that actually say, aspiration precautions, and it'll have all these things listed on it so that anyone else that comes in will be able to know how to take care of the patient to prevent them from choking on things. So their skin is an issue. Also, we want to make sure that we're educating our patients that when they go out, even if they're going for a walk, even if it's later in the evening, we want them to use sunscreen no matter what time of the day it is. If the sun is out, it's very easy for them to get sunburn. They lose a lot of their layers in their skin. and their skin's very thin, so it's very easy for them to get a sunburn. We want to avoid summer heat. We want them to wear protective clothing so they can wear a light shirt that covers their arms, some capris or some pants, some closed-toed shoes. They can wear a hat. And you want to tell them also to avoid the heat because it's harder for them to breathe in the really, really hot weather, and they're at risk for becoming dehydrated. So we want to tell them if they have to go out anywhere, schedule their appointments for maybe later in the afternoon. If they're going to go for a walk, maybe they want to go earlier and later in the evening when the sun goes down.
Professor Davis,
yeah.
Montalensa, can you let her in?
Yes, thank you. In the winter, we want to tell them to dress warmly. We want to make sure that they have access to warm clothes. Do they have a coat? Do they have warm boots and gloves and hats, things that they would need? Older people do not need to bathe as frequently as we do because their skin is at a risk for drying out super quickly. So we encourage them to bathe less. We want them to lubricate their skin. So we want to encourage them to use a good moisturizer on their skin every day. Nurses, we need to be very careful with certain procedures that can damage the skin. So one of the main things we think about is bed sores. So we know that their skin is thinner. We know that when they're laying in those same positions without moving on a regular basis, that those areas where there's prominent bones will break down. So we're talking about the heels, we're talking about the back of the elbows, we're talking about the back of the ears, their bottom, their lower back area, their shoulder blades, areas like that are really at a risk for breaking down quickly. So we want to make sure that we're moisturizing their skin. We're implementing those Q2-hour turns if they're not able to turn on their own. We want to get them out of bed and get them into the chair if at all possible. We want to be careful if they don't ambulate well. We want to make sure if we're transporting them to a test that we put them on a bed or a stretcher. So that way we can pull them over so we don't have to worry about them falling. And then the other thing we want to think about is, which is not listed on here, but when you are putting in IVs and you're putting on dressings, anything that has any kind of a dressing or a tape on it, you just want to be mindful because I've seen patients come in and they have, maybe someone came in early in the morning and did a lab draw and they put a little piece of gauze there with a piece of tape. And then later in the afternoon, the tech or the nurse went to pull it off and it takes a whole chunk of their skin with it. Their skin is literally that thin. So you just need to be very, very mindful. And then there we have a potential nursing diagnosis. So we have risk for impaired skin integrity or a risk factor for immobility. So which of the following changes are associated with normal aging? A, the outer layer of skin is replaced with new cells every 3 days. B, subcutaneous fat and extracellular water decrease. C, the dermis becomes highly vascular and assists in the regulation of body temperature. Or D, collagen becomes elastic and strong.
B.
B, very good.
Yep.
Yep. They lose that subcutaneous fat and that extracellular water, which makes their skin so thin and so at risk for being damaged. Very good. All right, so when we're talking about perfusion, so as we age, blood vessels become less elastic and they're often rigid and the blood doesn't flow so easily through them anymore. We know their venous return is going to become less efficient. They may have fatty plaque deposits in their arteries that develop or continue to occur in the lining of those blood vessels. So we're going to notice when we're doing our physical assessment that their peripheral pulses may not always be palpable or they may be very diminished. It's not surprising that these patients also end up with orthostatic hypotension because we don't have that good venous return anymore. Those blood vessels are less elastic. And then the body is also less able to increase the heart rate and the cardiac output with activity. These are all normal age-related things that we would see. Lower extremity edema may start to develop, and those lower extremities might be cooler, especially in your patients with decreased mobility because we don't have that good circulation anymore, and that blood is just pooling in those lower extremities. So, because of all the reasons I just told you guys, our patients can get that orthostatic hypotension. They can also get hypertension. They're at risk for developing heart disease, and then they're also at risk for developing a stroke. So some of the nursing diagnoses that we could give to these patients is, whoops, move my slide, risk for injury. So risk factors due to disturbed sensory perception. So that disturbed sensory perception can occur in the hands, in the feet, especially with that swelling. Activity and exercise intolerance is something else that we might see. And then another one would be risk for ineffective cerebral tissue perfusion related to clot, emboli, or a hemorrhage. So remember we said, and we're going to start talking about this in your next class, they're not getting that appropriate perfusion to all of their organs because the blood's not coming out of the heart at a strong enough force to be able to get to all the important organs. And then when it gets down to the bottom of the extremities, it sits there and it pools. So when it does, that's when you're at risk for developing a blood clot. So if you get a blood clot, it can travel and it can go into your lungs or into your brain. So what are some health promotion ideas we can give our patients? Well, we can teach them that we want them to exercise regularly as tolerated. We recommend 3 to 5 days a week, walking 30 minutes a day. That's a great start. If they're overweight, we want to reduce their weight. So we want to encourage them to exercise and have a good habit. You can implement all those things that we talked about in nutrition just last week. Foods high in fiber, low in fat, lots of protein, drinking their water. If they smoke, we want to encourage them to stop smoking. I do feel like at this point, even though we will educate them and tell them, they're pretty set in their ways at this point. It's not often that I see older patients quit smoking unless they get a diagnosis of lung cancer. That usually scares them. But by the time they get in their 70s and 80s, they're pretty set in their ways, but we still need to encourage them. So we want them to have that low-fat diet, low cholesterol diet, avoid any unnecessary stress, and then we want to make sure that they're keeping their extremities warm. So we could think of this in terms of when they go outside in the winter because they're more at risk for frostbite because of that loss of that subcutaneous fat. And then also just sitting around the house, you'll notice that they're always cold. When I go to my father-in-law's and I walk into his house, I feel like I'm sitting in a sun all weekend. He has it on 74 and 75 and he's still cold sometimes. So you want to make sure that they are keeping warm when they're in the house as well. So oxygenation. Oops. So some of the nursing implications that we will see with oxygenation, we might see an activity intolerance. If they're not getting proper oxygenation throughout their body, they're not going to be able to tolerate certain activity. That could be taking their normal walk a couple times a week. That could just be walking around the grocery store, even ambulating in their house. Another one would be ineffective airway clearance related to inflammation and presence of secretion. So this could be your patient that has aspiration pneumonia or just pneumonia. So some nursing interventions that we would want to do is that we would want to monitor their respiratory pattern. So we're going to make sure we're really watching and listening and measuring those respirations and making sure that they're between that 12 and 20 range, which we expect to be normal. We would want to administer oxygen as needed. If they require oxygen in the hospital and they're going to be discharged home, you want to make sure that if you think that they're still going to need that when they go home, that you recommend that for them so that they're able to do their ADLs at home. We don't usually keep patients in the hospital if they just require, if everything else is fine and they require just a little bit of supportive oxygen, we will call case management and they'll get a hold of the home nursing and they'll deliver some oxygen for them. And then that way they can use it at home until they're able to wean off of it. We want to encourage all of our patients to be using that incentive spirometer. If they don't have one in the room when you go in, make sure that you use that nurse-driven protocol that you have and make sure you get your patient an incentive spirometer so they can get that air in their lungs and prevent pneumonia. We want to encourage good fluid intake. Remember, we said that people at this age sometimes lose that drive to drink. They don't have the sensors that tell them that they're thirsty, so they end up getting dehydrated very quickly. And then we want to make sure we're positioning our patients to optimize the proper respiration. So we want to keep their head of the bed up, or we want to get them out of that bed and into that chair so that they're sitting straight up, so that their lungs are expanded and they can get as much air in as possible. Common health problems that we see are chronic lung disease. So as they get older, they lose pulmonary elasticity, and then that ciliary action, you know, that the ciliary that are in there that move back and forth, they help catch any kind of debris or bacteria that comes in. That's like kind of like the filtration system for the lungs. Well, that ciliary action decreases, and then the elasticity decreases also. So patients are not able to clear their lungs. And their respiratory rate can increase, and then their deaths are going to be diminished because they're working harder to clear the lungs. So chronic lung disease we see could also be from COPD, emphysema, people that have smoked, or patients that have had some kind of lung disease due to environmental issues. Maybe they worked in a coal mine, or maybe they worked around asbestos, things like that. And then they're at an increased risk of infection because they can't clear their lungs like you or I could. So health promotion for this, for oxygenation, again, regular exercise, moving the body, circulating that oxygen, getting that good oxygen into the lungs. If you smoke, we want you to stop smoking. Adequate fluids. A yearly flu vaccine, and a pneumonia shot. So these are really important for oxygenation because if these patients get the flu, so what happens is, you know, we hear people every year that die of the flu, and a lot of people are like, how do you die from the flu? Well, it's not really the flu that kills you, it's the pneumonia. So you get the flu and you start feeling bad, and when you're feeling bad, you go to bed because you feel bad. Well, you lay in bed, you're not moving, you're laying flat, you're not getting that air in. You keep laying around because you feel bad, then you develop pneumonia, you feel even worse. You don't realize you have pneumonia, you just think you're really sick with the flu, and then you keep laying in bed, and then eventually you get septic. So you get septic from the flu, it goes through your entire bloodstream, and then that's how people die of the flu. So we really need this population to get a yearly flu vaccine so that they're covered, so that they don't get the flu. I mean, we know we only cover against the top 4 strains, which we think we're going to see, but we do want them to get that flu vaccine and that pneumonia shot. And then we want to avoid exposure to upper respiratory infections. So during the winter, you know, we want to tell our older patients that maybe they want to go to the grocery store first thing in the morning because not a lot of people go. You want to avoid large crowds during the winter, during flu season, things like that. And then don't go around anybody, obviously, that they know has been sick. So nutritional concerns. So as patients get older, their digestive juices continue to diminish. So they're not good. Those enzymes, they don't multiply in the amount like they do in us. They don't have as many digestive enzymes. And then the way that they absorb nutrients from the foods that we take in also decreases. When this happens, they can develop malnutrition and anemia. This is very, very common in older adults. They have reduced muscle tone and decreased peristalsis, so they're at risk for developing indigestion and constipation, are common complaints that we see in this population. They also have diminished saliva production. So when they have that, it leads to them saying that they have dry mouths. Their mouth is dry. They can also have constipation, diarrhea, gas. These all lead to weight loss, sometimes weight gain, and it can cause adverse drug reactions as well. So some of the nursing things that we want to do to help these patients, we want to increase their fluid and their fiber because we want to make sure that they're not constipated. We're getting that good peristalsis. Intake and fluid will help with that. We want to be careful with hot food. So we want to caution them, remind them that their food is hot. They might not realize it. Remember, we said they have that decreased sensation. It happens in their mouth as well. They might not realize it's hot and it can burn their mouth. We want to monitor drug effects very carefully. So we said that they don't have the proper enzymes in their bellies to process certain things. Medication is one of those things. We know that absorption decreases. Medication, that's going to be affected as well. We're going to want to monitor their weight. So if it's a patient that's been there before, their information will be in the hospital, will be in your file from before, so you can always compare it. I always do that. You'll see as soon as you bring them into your computer, if any of their other information comes up, and you can look through their chart and just verify, hey, what was their weight the last time they were here? Wow, they've lost 40 pounds since they've been here. Maybe I want to inquire a little bit more to find out if this was an intentional weight loss, or maybe something's really going on with this patient. We're going to assess for malnutrition, many different reasons why. It could be because they've lost their appetite. It could also be that they have limited income. Maybe they have good money coming in, but they don't have access to nutritious foods. Maybe they live alone and they don't drive anymore. Maybe their family doesn't live close. Maybe they don't get around like they used to and they can't cook for themselves anymore. Maybe they need assistance preparing food, buying the food, or even maybe their vision isn't good anymore and they can't really see to safely cook or to feed themselves. So we really want to try, if we notice a problem, to get to the bottom of it so that we can, there's so many programs in the community, Meals on Wheels, things like that you can talk to the case manager, they can get set up for their patients. They'll deliver 3 meals every day to the patient. It's a great program, but we as nurses, sometimes we're the only person between them and a family member, especially if their family members don't live close. So we really need to advocate for them. And then we want to assess their swallowing ability. So maybe they're having problems swallowing. Maybe food gets stuck in their throat so they don't want to eat because it hurts. Or maybe they have indigestion every time they eat from GERD or something like that. It could just be a simple fix. They also lose their sense of taste and smell. They don't lose it completely, it's decreased. The sweet and the salty tastes are the ones that diminish first. And then sensitivities to odors may also be reduced. So all of these things put a patient at risk for nutritional imbalances. So we just really want to watch for them. So what can we do? What kind of recommendations we can make? So we want to encourage our patients to brush and floss daily. Keeping their mouth fresh will help them to be able to have good taste, increase their taste somewhat. We want to make sure they're having regular dental care, make sure that they don't have any cavities, make sure they don't have any pain when they're eating, they don't have any missing teeth. If their dentures are broke or if they just need dentures, they can have that all taken care of at the dentist office, and that can help with eating. We can encourage them if they're having indigestion and they don't have big appetites, so they can have small, frequent meals throughout the day. Making sure that those meals that they do have are packed with everything that they need. So we want it to be low in fat, but high in fiber. Some patients will take laxatives or enemas if they can't go to the bathroom, and that's okay. It's a help if they need it, but we don't want them to take it long term. We don't want their body to be dependent on using laxatives or enemas to go to the bathroom. We really want to try and get to the bottom of why they're having this problem, so that we can make changes in their diet or give them some kind of medication supplement that will help prevent this. We want to make sure we're toileting them on a regular schedule. Ask them when you come in the room if they have to go to the bathroom. Do they feel like they have to have a bowel movement? Giving them adequate fluids. And then if they do have dentures, making sure that their dentures fit properly. All right. And in the older adult, taste buds atrophy and they lose sensitivity and appetite may decrease. The older adult is therefore less able to discern A, spicy foods, B, salty, sour, sweet, and bitter tastes, C, hot and cold food temperatures, or D, moist and dry.
D.
D.
B.
Yep, B. Very good. All right, elimination. All right, so what are some common health problems we see with elimination? So in men, it's very, very common to have urinary retention from that enlarged prostate. With women, we see stress incontinence. So stress incontinence comes from sneezing, coughing, laughing, things like that. This leads them to any kind of urinary retention is going to make the patients be at risk for developing a UTI because that urine is staying inside that bladder and the ureters. And it's like the perfect area, dark and warm. It's just that bacteria is going to breed. So what happens in our bodies is, remember we talked a couple slides back, we have that decreased blood flow, right? We're not getting the adequate perfusion through the body like we used to. That means that the blood flow to our kidney also decreases because we have that decreased cardiac output. If we're not perfusing the kidneys, they can't work like they're supposed to. If you remember back to biology, we have what we call the nephron units, help filter everything out in the kidneys. Well, they decrease in this population of adults by almost 50%. That's a huge amount. Waste products cannot be filtered as they used to be. The filtration and the excretion that we see is much slower, which can cause adverse drug effects because technically they have renal failure. Their fluid and electrolytes tend to remain within normal ranges, but it's a very fine balance. So it's very, very easy to tip the scale with these patients one way or another. And you see it happen all the time when you take care of them. They come in, they're dehydrated. We give them fluids to get them hydrated, but then we put them in congestive heart failure. Very easy for that to happen because they're very fragile. Their bladder capacity also decreases by 50%, so they can only hold half of what they used to be able to hold. They start frequenting more often. When they urinate frequently at night, we call that nocturia. We consider it nocturia if they get up 2 or 3 times a night. And remember, urinary urgency and frequency puts these patients also at risk for what?
False.
Yes, very good, Shanoa. Falls. They're getting up, they're having to run to the bathroom, and they move pretty quickly because if they're not wearing pads or something, they don't want to soil themselves. And then you have that throw rug in there, or maybe the, what's it called? The little light that you can put, what are they called?
Nightlight?
A nightlight. Yes, I swear I lose track of like the most common words. If they have a nightlight or they don't have a nightlight, or maybe it burned out and they can't see where they're going and they trip and they fall. They have a decrease in their bladder and their sphincter muscle control. So that's what leads to that stress incontinence or that incomplete bladder emptying. About 75% of men over the age of 65 do experience some kind of benign hypertrophy, which is an enlarged prostate. We call that BPH. Sometimes if it causes urinary retention and they start to have a lot of UTIs, they can do surgery. If not, it's just something that they monitor. You will know the patients that have prostate issues if they have retention issues in the hospital when you have to straight cath them or put a cath in. It's very hard to get the catheter past that prostate because it's so big. So sometimes urology has to come do it, or you have to put in what we call a coup-de cath. So a coup-de cath is different than a regular cath. It kind of has like a C on the end of it, and it's curved so that it can go right around that prostate. These conditions, so all of these conditions leave this population of people susceptible to developing UTIs. Remember, one of the most common side effects or symptoms that you will see of a UTI before you see urinary issues is going to be that confusion. This is how the older population presents. And then with the older women, their genital tract begins to atrophy, and this is associated with the lining of the uterus becomes very thin, and that causes a decrease in vaginal secretions. So we are going to want to increase their fiber intake, monitor their output. We are going to make sure that they have access to a toilet. So some of your patients, if you know that they can't get to the toilet, our rooms are small, but sometimes they can't even get into that bathroom because it just comes so quickly. Advocate for them and get them a bedside commode. Put it right next to the bed. That way, that all they really have to do is stand and pivot. It's kind of degrading for these adults when these things start to happen and they're incontinent, but their mind's still there because they feel like they should be able to get to the bathroom one time. It's degrading, it's embarrassing. Even if you get a bedside commode, it's going to make them feel more independent, and it's not going to make them feel so self-conscious about it. Make sure that in the room at the hospital, their floor is not covered. Push that bedside table away. Make sure their chair's out of the way. At home, make sure you talk to a family member or encourage the patient to make sure that they clear that path from their room to the bathroom, wherever their bathroom's located. Make sure they have easy clothing to remove. Some of the times you see these older patients, these men will wear the pants with suspenders. Probably not a good idea if you have to pee every 20 minutes and you can't hold it all the time. It's going to make it hard for you to try and get all that off. So comfortable, free-moving clothes. Making sure that they're having adequate fluid, but not too much fluid. Also telling our patients to drink more during the day when they're up. Maybe they want to stop drinking by 8 or 9 o'clock at night, a couple hours before they go to bed. So that way they are not up all night going to the bathroom. We can encourage them to do pelvic floor exercises, Kegels, to help build those pelvic floor muscles. We want them to have good perineal hygiene. We said that they're not getting a bath every single day, but they can get what we call a little bird bath by the sink. They can stand at the sink or put their bedside commode or their shower chair by the sink and then just wipe off with a warm rag every day. For men, we want them to go every year to have their prostate checked by the doctor. And then we should also be looking at labs, the PCA, which is the prostate specific antigen. This is not always, they used to think this was a very measurable indicator of prostate cancer. The most recent studies have shown that it's not. We still pull it, but we use it in conjunction with that prostate exam and then biopsies as well, because there's a couple other different things that can elevate that PCA. So it's not an adequate finding like they thought it used to be. A client has been diagnosed with stress incontinence. The primary goal of caring for this client is to A, help the client adjust to frequent episodes of incontinence, B, eliminate all episodes of incontinence, C, prevent the development of urinary tract infections, or D, decrease the number of incontinence episodes. What do you guys think?
A.
A.
So actually the answer is D. D. So we don't want to tell them you just have to deal with this. You know, this is something you have to deal with. We want to try and find things that we can do to decrease the number of episodes. So we can, one of the things I just told you that you could do is tell them to stop drinking after a certain time so that at nighttime they don't have so many issues. We can do behavioral interventions through diet and exercise. If they're overweight, they can, if they lose weight and they start exercising, that can help. We can give those pelvic floor exercises, which will help build up those muscles. There are medications that we can use that will help those minimize those episodes. There's always surgical interventions that we can use, but in this age population, you really want to make sure that they're a good candidate for that. Without surgical intervention, it's not probably possible to eliminate all episodes of incontinence, but we certainly can decrease it, absolutely. We want to help the client adjust to the incontinence, but it's not going to treat the problem. We want to try and treat the problem. And then clients with stress incontinence, I mean, if you were thinking that maybe it was C, it's not really C, because if they're getting the pee out, it's not really staying in there and they're not really at risk for that urinary tract infection. So mobility, common health problems. So as patients get older, we said they have a decrease in subcutaneous tissue and also weight. This is a very common finding. Their muscle mass and their strength decreases. They have bone demineralization, so their bones become porous and very brittle. This is why this population of adults is so susceptible to having a fracture if they fall. That's why we really, really need to prevent those falls. As they get older, their joints tend to get very stiff. They lose some of their flexibility and their range of motion is decreased. Because of all these things in combination, overall, we see as their mobility starts to slow down, their posture tends to stoop, and then this is where they lose height. So they can lose between 1 and 3 inches. So common health problems that we see, well, osteoporosis, because of all that bone demineralization and because the bones are porous and brittle, leads to osteoporosis. We see those fractures, and then we also see arthritis. So some nursing implications that we can do to help them. Well, we want to encourage that exercising. We want them to walk 3 to 5 days a week, at least 30 minutes a day. If they're overweight, we want to encourage weight loss because the more weight they carry, the more of a strain it is on their bones. We want to encourage them to be safe at home. So we want to talk to them about moving, using a nightlight, moving throw rugs and things out of your way at nighttime so that you have a clear path to the bathroom. Unclutter their environment with good lighting and then removing of those throw rugs. There has been many studies that show that regular weight bearing, not just cardiovascular activity, but those weight bearing exercise are ideal for this older population. This is really what helps with their bones and keeping them strong so that they're not losing their balance and having these safety issues and these falls. We just want to make sure that their home is safe. There's a lot of programs in the community. If these patients live alone and they don't have family members, you can coordinate with the care manager. They can contact these companies or these programs in the community that will come and look at their house. They'll look to make sure that their steps are safe, that their bathrooms are safe, and they look at their income. And most of the time they'll put up handrails. I know when my grandmother was living by herself, they came and they redid her whole bathroom and made sure she had bathrooms in her handrails. She had a couple missing tiles in the kitchen. They put her in a new floor. They put her new handrails outside on her main steps going into the house. So these programs are great. You just have to talk to the case manager. You want to prevent those falls. Make sure that if necessary, they are taking in some calcium through supplementation, and then some getting good vitamin D. So if they're outside in the sun, or they can also make sure that they are incorporating it into their diet, because remember, our bodies don't make vitamin D, so we can only get it from our environment and the foods we eat. Sensory perception. So as they start to get older, they're going to have decreased visual acuity. So we call that presbyopia. It's decreased visual acuity. This comes with, and they may say that they have an increased sensitivity to glare. They might say that when they're driving at night, the headlights coming towards them really hurt their eyes, cause their eyes to burn. They can't see after that for a couple minutes. They have a difficulty adjusting their vision to darkness. They have decreased accommodation. They have decreased depth perception and decreased color discrimination. If they have cataracts, which a lot of these older people do, it's going to even further add it to that vision deficits that they have. So when they have all these issues going on, this is going to cause them to have difficulty reading small print. And then, like I said, the daytime and the nighttime driving can also be compromised. So if they have all this stuff going on with their vision, this is another thing that's going to contribute to them being a fall risk. Some of the older patients also develop glaucoma, which is an eye disease that can cause complete blindness, partial vision loss. It's actually when the nerve in the back of the eye, your optic nerve, becomes damaged. It is treated by surgery. Macular degeneration is another age-related disorder that you'll see. It's actual deterioration of the macula, which is that small area in the center of the retina of the back of your eye. It does cause central vision loss. And central vision loss is what you see in front of you when you're looking straight ahead. We actually have, I don't know if Dr. Ertwein's going to pull them out this Saturday, but we actually have glasses, and they have different lenses that you can put in them, and then you can see exactly what these, what glaucoma, what macular degeneration, and all those would actually look like to the patient. They're pretty cool. So I hope we get to use those this weekend. They also have issues with their hearing. So presbycusis, this is decreased acuity in their hearing. They really struggle with pitch discrimination, especially when they have environmental noises going on, when there's a lot of people around. Sometimes they just have wax buildup in their ears. This is very, very common for this population. As a result, they're going to have hearing problems. They have amplification issues, so they're going to need hearing aids. And then you might notice that older adults withdraw from certain social events. And this is pretty common because they feel like they can't adequately participate. So it's hard for them to hear. They feel like they're always saying, what? It's embarrassing. They can't see as well. So they, often when they're invited to do things, they'll just say, no, I'm going to hang out at home. And then that loss of social interaction also leads to other issues. So it's definitely a trickle-down effect. Their senses of taste and smell are decreased. We said those sweet, salty, and bitter tastes diminish first. Sensitivity to odors are also reduced. So what do we want to encourage for these patients? We want to encourage regular eye checkups. They should be going to the eye doctor every 2 years, or sometimes every year, depending on what kind of issues they have going on. We want to encourage them to use glasses if they need them to see. We want them to wear sunglasses outdoors. We want to make sure that their home has adequate lighting so they can get around inside the house and navigate. We want to recommend that they avoid nighttime driving if it really bothers them, the other lights of the oncoming cars. We want them to be safe. We don't want them to hurt themselves or anyone else, so they should probably just avoid nighttime driving altogether. We want to recommend that they have either a magnifying glass or they can buy large print books. They have word searches and crossword puzzles in the dollar store. You'll see them all the time. They come in that large print. We want to make sure they're going for their hearing exams. Try and reduce the background noise. So if you are educating your patient about something or you're talking with your patient and you know that they have an hearing issue, make sure you mute the television or close the door and just let them know, I'm having a hard time hearing you. I'm just going to mute your TV. You can always say that it's you, not them. Make sure you're speaking directly at them so that they can see you, because some patients, as they get older, even if they don't want to admit that they have a hearing problem, they have learned to watch your lips. So they can, if you're standing right in front of them, it's a little challenging now because we're wearing masks all the time and they don't get to see our lips, but just a couple months ago, that wasn't the case. We would be able to stand right in front of the patient. They could read our lips. Speak in a low-pitched voice. It's going to be easier for them to understand. We can also use verbal cues. And then to help with those taste buds, we can use lemon, spices, and other herbs to help make their food taste more tasty, make it more appetizing and appealing, and help with those nutritional issues. Question, in the older, oh, we already did this one. I don't know why it's in there twice. All right, let's see. Actually, this was the one. that was supposed to be in here. And let me copy this so you guys can see it. I don't know why yours is like that. Oh, mine was the one that had it twice. Okay, never mind. This is yours. All right, visual acuity declines with age. Presbyopia is a progressive decline in A, the ability to see in darkness, B, the adaptation to abrupt changes from dark to light, C, the ability of the eyes to accommodate for close detailed work, or D, the ability to distinguish between blues, greens, and among pastel shades.
C.
C.
Very good. Yep, it's C. All right, so reproductive health promotion. So normal aging does not affect libido. Illnesses affect libido, loss of a partner will affect it, social isolation, those things affect libido. Health promotional activities for this, we can recommend sexual counseling. We can encourage, especially for those menopausal women, the use of a lubricant, because we said everything thins out. They lose a lot of moisture. It can be very painful for them to engage in sexual intercourse, so we can recommend the lubricant. For men, we can recommend medication such as Viagra. And then the use of estrogen is very helpful for women sometimes, but it does come with side effects. A lot of cancers, so you have to leave that up to the doctor, but you can advocate for them and recommend that. So when we talk about their neuroregulation, so some of the things we're going to want to think about with the older adult is we always want to question sudden confusion. If your patient is always alert and oriented, or if you're an emergency room nurse and your patient comes in with their daughter and they say, Melissa, I don't know what happened with her. I live with her. She's always alert and oriented. She walks with her friends every day. I got up this morning and she was just saying things that didn't make any sense. She didn't know me. She didn't know my son. We always want to question some kind of sudden confusion. It's usually related to some type of infection in the body. UTIs, that's the first thing we're going to want to think. We're going to want to encourage our patients that when they get up in the morning, that they get up slowly. Get up slowly, sit on the side of the bed, let your feet dangle, make sure your feet are on the side or on the floor. Sit there for a minute, make sure you're not feeling dizzy. If you are feeling dizzy, don't get up. You want to encourage visitation of family members in the hospital. This is hard now because we don't have visitors in the hospitals right now, but hopefully when we get back to more normal times, we'll be able to do that again. And then we want to encourage our patients to interact with others when they're not in the hospital. We want to provide for sensory stimulation, encourage the use of a walker or a cane if they need it, make sure that they have access to it, make sure that if they didn't come in with one and they need one, make sure that when they're discharged, they have one. So we would want to talk to PT or OT and make sure that it's covered by their insurance and make sure that they have one. As nurses, we always want to make sure that we can distinguish between the 3 Ds. And the 3 Ds are delirium, dementia, and depression, because we want to be able to make sure that we're selecting the appropriate nursing interventions. We're going to talk about all 3 of these in detail. And then if you think necessary, make sure that you are consulting a gerontological specialist, depending upon whatever it is that you see. So delirium. So when we think about delirium and dementia, one of the biggest differences is that delirium is a temporary state of confusion. It does not last. It is usually related to an acute illness that has a specific underlying cause. It can last from hours or weeks, and usually it resolves when you treat the underlying issue. So if we use the example of the patient that has a UTI, once we identify that it's a UTI and we start those IV antibiotics, you're going to quickly see your patient come around, and they're going to be completely different than they were when they were admitted. So it's a temporary state of confusion. That's the main difference between delirium and dementia. Dementia is not a temporary state. Delirium is. Delirium may not have just one specific cause. In older adults, it could be caused by those drug interactions. Remember, we said their kidneys are not filtering like the way they used to. It can cause toxic levels of different medicines to build up in the body, which could most definitely cause confusion. They could have circulatory or metabolic issues, any kind of nutritional deficiencies, or worsening illnesses that can trigger certain inflammatory responses, and which in turn can cause a disruption with the patient's neurotransmitters, which can cause these states of confusion. So when we think of nutritional deficiencies, we also want to think of the effects that they have on their medications. So some medications that we give patients are based on their weight. So I always like to use my grandmother for this example. She used to take a certain dose. She had AFib, so she always took a certain dose of metoprolol, and she had AFib for 25 years. But as she got older and she was living by herself, her appetite decreased. She didn't eat as much. She lost over 70 pounds. Her level of metoprolol never changed, and it needed to. This caused issues for her with her heart. She was having, her blood pressure was extremely low. Her heart rate was very low. She was passing out. She was having falls. So those are also things that we want to think about when we know our patients don't have good, adequate intake, or if we see that they're losing a lot of weight. During acute illnesses, older adults are very at risk for delirium because they have a big decrease in their cognitive reserve. Sometimes being in a different environment, it happens a lot in the ICU. If they've been on ventilators and things like that, it just happens from having a change in their environment, a lot of stimulation going on 24 hours a day when you're in the ICU, or just even in a hospital. We're constantly coming in, we're doing labs, we're doing vital signs, we're giving you medications. These are all things that can trigger delirium in patients. You will see an increase in the incidence of people developing delirium that have certain risk factors, such as cognitive impairment. So these people are at more risk for developing delirium if they've had sleep deprivation, if they're immobile, and then if they have visual or hearing impairments, and then in patients who are dehydrated. And then we want to watch out for any kind of rapid fluctuations in symptoms. So any increase in variances with those blood pressures, heart rates, temperatures, all of our vital signs, labs, things like that, we want to just take into consideration. Let's see. And I didn't turn the slide. Sorry, that was my fault. This is the slide I was just talking about. So delirium, again, is an acute confusion state. It's acute, it will not last. It's potentially reversible due to that psychological cause, no matter what it is, drug interaction, UTIs, metabolic or circulatory deficiencies. It can be a very sudden onset. 1 hour they're fine, the next minute they're not. We can see some other things that can cause it are those electrolyte imbalances, cerebral anoxia. So a cerebral anoxia event, that's when we're not getting good oxygen to the brain. So sometimes if patients are very anemic or they don't have good oxygen circulation, then this is when we see the cerebral anoxia. And then if you fix the issue, if you give them a blood transfusion and they have more of that oxygen-rich blood circulating, or if they're having, maybe they have pneumonia and they just aren't getting good oxygen, if you give them that supplemental oxygen, you will see these issues turn around. A couple years ago, I had a patient who was completely fine in the morning. He was on 4 liters of oxygen. He had pneumonia, and I had given him all of his meds. He was fine. And then like early afternoon, he started coming out he was telling the secretary that he needed to get someone in the room to get rid of the cat, that the cats were jumping all over him, trying to attack him. And I was like, okay, that's weird. Let me go see. Well, he had his oxygen off. So I don't know how long his oxygen had been off, but somehow he got it off. And then he wasn't he wasn't getting that good oxygen to the brain. So then he had this sudden onset of confusion, which resolved pretty quickly within about 45 minutes after I put his oxygen back on again. So just some things to think about. If your patient has hypoglycemia, very low blood sugar, they can completely pass out and be unconscious, or they can be very, very confused. Tumors, any kind of brain tumors, any kind of metastatic disease that spreads to the brain. So in the oncology world, if we have a patient who has certain type of cancers, and when you work in oncology, you get to see these patients on a pretty frequent basis, and you've seen them before and you know what kind of cancer they have, and then you know what type of cancers can spread to the brain. So we would have different patients that would come in, and we'd see them come from the emergency room, and their admitting diagnosis would be confusion. And the first thing we would think is that now they have brain mets, and 9 times out of 10 they do. Certain medications can cause it, and then those systemic infections. So confusion is often the very first sign with those systemic infections. So how do we treat it? We focus on treating that underlying cause, and then we return, you're going to see that return to their current baseline of cognitive function. We would stop any unnecessary medication if we think that that's the problem, resolve any infection and any kind of metabolic alterations, and then we want to avoid sedation. This can contribute to more increased confusion, and then it can cause sedation. So you want to use Ativans, Valiums, pain medicines very, very cautiously, because they're already confused and it can make it worse. So then we have depression. So depression is, it is defined as extreme or prolonged sadness. Depression is not a normal part of aging. In the older adults, I feel like they are more susceptible to depression because of different things that they deal with. So as they get older, they might have a death of their spouse or death of very close friends. They may see their mothers and fathers are gone, their brothers and sisters are gone. I've heard patients say that they're just sad because they're the last one of their family members that's left. It's very hard. I mean, getting old is a privilege denied to many, but when you do get old, there are certain things that come along with it, and sadness is one of them, because you miss your family, you miss your living life the way that you used to be able to live, being able to take care of yourself. It's very hard for older adults to become dependent on other people. And it's very hard for them to realize that they can't do the things that they used to be able to do. So death of a spouse, friends, not being able to take care of themselves anymore sometimes causes a change in their living environment. And that is extremely hard on them. Financial situations can also cause problems, depending if they don't have enough money for food, or they don't have enough money to pay their bills, or they don't have enough money to even get their prescriptions. This can lead to feelings of depression. There isn't usually a distinct behavior that comes along with depression. It's more just signs and symptoms that we see. And sometimes we overlook them because these are just signs and symptoms of so many other things. So it's important that we try and look at older people in a holistic perspective and make sure that we're treating everything. So some of the signs and symptoms you may see is they may have sleep disturbances. Well, as you get older, sometimes you have sleep disturbances, especially if you're up peeing all night. Weight loss or gain. We gave you all the reasons why just a few slides back, why they start having nutritional deficiencies and why they lose weight. Difficulty concentrating is a sign. You might notice that they're more irritable or angry, and they may have a loss of interest in previously pleasurable activities. Well, we also said that if they can't hear and they can't see, that also tends to have them withdraw and not be as social. Sometimes depression will cause pain. So they might complain of vague pains. They might be, maybe they're tired all the time. They could cry a lot. They may be very fragile when you're talking to them. Sometimes they might have suicidal thoughts or a preoccupation with death. So really all the things that we just talked about are all the things that we've seen related to other issues. So you can see why it would be hard to diagnose depression. If you ever think that your patient is depressed, you can always get a psych consult for them. Let the doctor know, they'll order a psych consult, they'll come and talk to them. They'll do, they can do a geriatric depression scale exam. It's like a 15-question screening tool. It is very effective with older adults. And when you combine that assessment with the assessment of a mental health professional, it can help diagnose depression, and then they can start medications on them. They can put them in touch with outpatient therapy so that they can get the help that they need. Depression is reversible through certain behavioral exercises and medication. It also can occur with dementia, and it greatly increases family stress. You want to look for onset of depression to coincide with major life events. If they tell you they lost their loved one, their wife of 45 years, this is how these things start. If they tell you he lived by himself his whole life and now he had a couple falls and now he has to live with his daughter, or his family won't let him drive anymore because he had an accident. So these major issues coincide sometimes with a diagnosis of depression. Depression does occur in 7% of the older population. And then, like I said, we can do psychotherapy outpatient, and they can also go on antidepressant medications. So dementia. Dementia is the most common form of dementia that we see in our patients is Alzheimer's. It is the most common degenerative neurologic illness, and it is the most common cause of cognitive impairment in these older adults. It is irreversible. Remember, we said delirium is reversible, dementia is not. And it progresses from deficits in memory and thinking skills and leads to eventually an inability to perform basic self-care, so your ADLs. As a healthcare provider, if you're working in a primary care facility, you're going to want to reassess their functional ability with each change in their health status, because you're eventually going to see this gradual change. So each time they come in and they come in with a loved one, you're going to want to assess their inability or their ability to perform certain things and compare it to a previous visit. When you have a patient that presents with dementia, if you can, if they didn't come with a loved one, you would want to rule out delirium first. Make sure they don't have any kind of underlying infections. Make sure it actually is dementia. Let's see. Dementia refers to various organic disorders that progressively affect their cognitive function. There are different types of dementia. There is Lewy body dementia and vascular dementia. They also have frontal temporal disorders that can cause dementia. Alzheimer's is the most common neurologic disease that we see in this older population. What happens with Alzheimer's is they start in the brain structure, the brain starts to form these, what they call amyloid plaques. And they also call them tangles of tau protein. So it's these buildup in the brain. You can actually see it on MRIs. At this time, there is no effective medical treatment. There's no cure for it. Usually the first indications of Alzheimer's occurs usually in someone in their mid-60s. Sometimes you see it a little bit earlier. I've seen patients in my nurse practitioner clinicals with Lewy body dementia in their late 50s, early 60s. Nearly half of all 85-year-old adults have this disease. That's a lot. Half of 85-year-olds, that's a good population of our older adults. And scientists recommend that at least 5 million people have Alzheimer's disease. It is very progressive, it is serious, and it is ultimately fatal. In mild or early Alzheimer's disease, you will see that they suffer with forgetfulness. Their judgment is impaired. Over a period of several years, as the disease progresses, the person progresses to what we call mild or middle Alzheimer's. They become more progressively confused. During this stage, they might start to not recognize their family anymore. They can become very disoriented, even in familiar surroundings. So if they're still living in their home and they've lived there for 50 years, they might not know their home anymore. When they lose the ability to performing simple tasks, and they can't, bathe themselves anymore. They can't feed themselves anymore. This is when they enter into what we call the severe or the late stage of Alzheimer's. During this stage, the person is going to require constant supervision and care. Often you see these patients they're in long-term care facilities. It's very hard for family members to take care of patients that have Alzheimer's, especially if they have to work. They require a lot of care. They require constant orientation. If they don't know who you are, sometimes I've seen family members come in, they try and spend the night with their family member because they get confused at night. And the loved ones, the patient will try and, at one time I saw a patient try and beat their son up. I saw women patients not recognize their adult son. They thought that the man was there to rape her. It's very, very hard for the patient, and it's extremely hard for the family. So when you're caring for a patient that has Alzheimer's, you are caring for that patient and that family member, because it's really hard for them to see their loved one like this. It's very sad. And there is no effective medical treatment at this time. So there are some medications that I see patients get earlier on when they're advanced, when they're first diagnosed with it, that is supposed to help with memory. Some patients say it does, some people say it doesn't. It really doesn't stop that progression. We more so manage these symptoms. So the symptoms of confusion, and that symptom when they're scared and they're trying to hit people and they're being violent, we would want to give them medicine to help keep them calm. So when you are dealing with these patients and you're giving them education, you're going to want to remember that they can't take a lot of information in. So you're going to want to make sure that you make your information as brief as possible, really touch on the important points, make sure you give them clear instruction, okay? And you want to make sure that you're phrasing your information to them so that they understand you. You're not going to want to include all those medical terminologies that they won't understand. So education, keep it brief, make sure you have clear instructions, and make sure that they're phrased positively. All right. Health promotion for psychosocial concerns. So we want to make sure we're using therapeutic communication. We want to express concern, we want to be kind, and we want to offer compassion, not only for the patient, but for their family members as well. Want to make sure that we're using appropriate touch. So sometimes this can, like in the picture here, she's putting her hand on their shoulder. It can convey respect, it can convey sensitivity, it can also make them feel secure, especially when they're scared, when they're looking for their family member, or they don't know where they are and they think they're locked up somewhere. Sitting on the bed with them, giving them a hug, holding their hand really is therapeutic, and it lets them know that you are listening to them and that you're trying to keep them safe because they don't feel safe. We can do reality orientation. So this helps to restore a sense of reality. So you would want to remind, if you ask the patient where they are, they'll say, I'm in my basement. No, Mrs. Jones, you're not in your basement. Remember, you're at GBMC. I'm Trish. I'm going to be your nurse. This is your hospital room. Sometimes that's not helpful. They get even more pissed off. And then, sometimes I just listen to them and I say, I know that you're upset. Try and encourage them to sleep. You really don't want to keep on fighting with them and going back and forth because you're not going to win. They're not going to understand what you're saying. They're not going to believe you. So just try and orient them as best as you can. But if you see they're getting agitated, then you would stop. Validation therapy. So this is, so when you have patients with dementia, we don't want to challenge them and we don't want to dispute what they're saying. So sometimes if they tell me that they're waiting for their daughter to call, I'll say, she tried to call earlier, you were you were asleep, she wants you to go back to bed, she'll call you tomorrow. We can use things like that. We don't want to challenge them and make them seem like they're even more confused than they are. Reminiscent therapy. So I will try to talk to my older patients about things that happened when they were younger, because usually their long-term memory comes in waves and it's intact sometimes. So I'll say, tell me about your husband, tell me about your wife. Do you have any kids? Where did you grow up? What did you do? You still work? What did you do before you were retired? Anything to change the subject. Sometimes when they reminisce about their loved ones, it jogs their memory and they remember certain things, which is helpful to them. Body image interventions. We can help the older adult present a socially accepted image. So if they're not able to care for themselves like they used to, we can make sure that we have some home care nurse come in and help them bathe, help them do their hair. These things make them feel good about themselves. Validation therapy also helps bring the patient with dementia back to our reality, but it's also, it can also be more positive to enter their reality. So when we do that, we're empathizing with them. When we empathize with them and they know that we understand how they feel, that's going to help them build trust with us. And then in turn, it makes them feel secure. And if they feel secure with us, their anxiety is going to be lower and they're more likely to listen to what you say, take their medications, try and get some sleep. It's not always the case, but sometimes they are redirectable. So abnormal age changes, disorientation, not a normal age change, loss of language skills, not being able to talk, not being able to find those proper words. So dysphagia. Dysphagia is when, not dysphagia, things like you might read in your book where they say word salad, where they use a whole bunch of words that don't make sense, or they have trouble finding the exact word to use. They also may be slower to respond. They have a loss of ability to calculate, so they can't, put one and one together to make two. They have a hard time making judgment about certain things. These are all things that you can see, but not things that are normal. The mental impairment that we see, we're going to see that dementia, Alzheimer's disease, sundowning syndrome. So sundowning occurs when the sun goes down. It starts anywhere at 3 o'clock and lasts all the way until the sun comes up the next day. These patients will change between night and day. You'll get reported in the morning that they were the most evil little gremlin ever, that they screamed and they hollered and they cussed all night long, that they jumped out of their bed, tried to beat you up. And then in the morning when you go in at 8 o'clock to give meds, they're so cute. They're sitting there, they're smiling, they want to take their meds, they're so happy, complete night and day. We call that sundowning. They get very restless, they get very confused, they get very agitated, wandering. They definitely want to get out of their room because they don't think it is their room. They call for their mom, they call for their dad. They don't remember that their parents have passed away. They're calling for loved ones that aren't there anymore, or loved ones that are here that aren't with them. Many times the alarm goes off and before you can get to the room, they've already thrown their legs over to the bed. They're completely buck naked and they're running into another patient's room. These people are quick, especially if they're in good shape otherwise. So you want to make sure you have all those safety interventions in place. You want to make sure you have your bed alarm on. Maybe they're going to wind up in restraints to keep themselves safe. Sometimes you need a sitter to sit in the room. Sometimes you can try and group all your older people, all your confused patients in one little cubby and then have one person sitting there and monitoring them. Cascade iatrogenesis is this is basically just when they have one event starts to happen, and then it precipitates this downward spiral, and then they have this big period of decline. So this happens in our frailer older adults, and a good example of this is maybe your patient gets up at night at home to go to the restroom. They're peeing a lot, they get up, they didn't move that throw rug, they fall. When they fall, they break their hip. They go into the hospital. When they're being hospitalized, they have to have hip replacement surgery. During the hip replacement surgery, we put in an indwelling catheter because they can't get up to go to the bathroom. And we want to monitor strict I's and O's. Well, because they're in the hospital and now they have a indwelling catheter, now they bought themselves a UTI. So they get confused. They didn't catch it in time. They turned septic. They ended up in the ICU. Now we're using antibiotic therapy. Because they're getting so many antibiotics, they might develop an antibiotic-resistant organism while they're in the hospital. And then they never return back to their previous health condition. You know, maybe they can't live alone anymore. So this happens many times in older adults. You'll see this with different patients. So you guys know about spices. This is an assessment tool that you can use. It's a systematic approach to developing potential issues or actual issues with your patients. You guys are working on a paper right now. These issues can lead to negative patient outcomes, so we want to be able to identify them and provide nursing interventions to minimize them, and then recognize issues that they don't have yet and figure out ways that we can prevent them. So the S stands for sleeping disorders, the P stands for problems with eating or feeding, the I stands for incontinence, the C stands for confusion, the E stands for evidence of falls, and then S is skin breakdown. So you can use this in any setting, even in the hospital. We use it a lot in our long-term care facilities because we really get a good picture of what they're like in their everyday life. But it's a very good intervention to help plan care for your older adults. So when we educate our patients when they're going home, no matter, maybe we're giving them a new medication, maybe they're going home with a walker, maybe they're a new diabetic and they have to deliver insulin. When we're teaching them, we want to make sure that we have what we call a teaching plan checklist. Some of your programs in the hospitals will have these for you to follow, but just some of the things you really want to keep in mind is you want to make sure that when you're teaching them, you have a quiet environment. So shut that door, turn the television off, ask them not to take any phone calls because you really want them, you want that one-on-one time to be productive. You want them to really understand what you're saying, make sure that you get your point across, make sure that you address any questions that they have. You want to assess their readiness to learn. So you probably don't want to teach them after they've worked with PT and they're in pain. Or if they've had a hip fracture and they're going home, maybe you want to make sure they've had their pain medicine first. Or if you notice they get really tired in the afternoon, maybe you want to do your teaching in the morning, or you want to do it after their nap in the afternoon. You want to value any prior experience that they have. So, if they've cared for a loved one that has had a hip replacement or a hip surgery, or that has, maybe they had a wife or a husband that they took care of that was a diabetic and they gave insulin to them, see what they know already and then build on that. Assess for any sensory deficits. Use appropriate language, especially with the older population, to try and stay away from that medical terminology. Speak in a language that they're going to understand. You want to make sure you include their family or their significant other. So if they don't live with family and they live by themselves, it's always a good idea to keep that one family member involved and let them know what's going on. Go over the discharge with them. Make sure they have the proper education so that they can check in with their loved one and follow up with the loved one. And if they have a significant other, their wife or their husband or their live-in boyfriend or girlfriend, make sure they're there also so that they know what they need to implement when they take the patient home. Pace their learning. If you're going over a lot of learning things, you want to break it up, chunk it. Make sure the patient's not getting overwhelmed. If you have 6 or 8 things to go over, maybe you want to go over 3 in the morning, 3 after lunch, and then 2 after dinner. Think about anticipating what you're gonna teach them before the actual day of discharge comes. So that way you can look at everything that you have to teach them, and then you can develop a plan so that you can pace your teaching. Sit down. And when I go over discharge instructions with the patient, I bring my chair and I sit right next to their bed and I take my time. I make sure that all my stuff is done and taken care of, and I actually can give my time to that patient because I want them to be successful with their treatment. We don't want them to have to come into the hospital again because they've had a fall or they didn't take their medication the right way. So sit with that patient, face them, make sure they can see you, hear what you're saying, speak slow and low, especially those patients that have problems seeing and hearing. You want to emphasize concrete concepts. So make sure if you want them to make sure that they're checking their blood pressure before they give their insulin, say it over and over again. Type it up, make it bold, put a star next to it on their discharge instructions, highlight it with a highlighter. Whatever you know that is going to be effective to get them to go back and look through the information and understand what those key concepts are. And then at the end, make sure that you summarize and reinforce. So I would say, Mr. Jones, we talked about a lot of stuff today. Tell me what is the most important thing that I want you to do when you go home before you administer your insulin. All right, I'm going to make sure I check my blood sugar. So get that feedback from them. Make sure that they can say back to you what those key points are. And then safe medication administration. We want our patients to be safe when they're taking their medicine. Oops. So in addition to the numbers of medication, the amount of medication that's taken by the elderly population, there are also other reasons that we should be concerned with medication concerns in this population. We want to be concerned about our altered pharmacokinetics. We want to think about their metabolic issues, their kidney issues, their GI motility. How well can they take these medicines in? How well can they break the medicines down? Is their kidney function going to cause toxic levels of certain medications to build up? We want to think about these things. Any atypical adverse drug effects. If you know that your patient really doesn't have a great appetite already and she's lost a lot of weight and we really want her to increase her appetite and that caloric intake, we probably don't want to prescribe a medication that's going to cause that problem to be exacerbated. You would want to talk to the doctor and say, is this a good fit for her? Or do we want to change the way that Ms. Jones takes this so that it doesn't affect her nutrition status even more? You want to clear any misunderstandings about medication. So one I see all the time is that patients that take Lipitor or atorvastatin, the same drug, is a drug that we give for patients that have high cholesterol levels. Well, a lot of these patients take it during the day when they should be taking this medication at night. It's better taken at night because that's when our body secretes and makes cholesterol. So it's very important that we take that medication at night. So we want to make sure that you clear up any kind of misunderstandings about medications. You want to make sure they can afford their medications before they go home, not when you're going over it in discharge. If you see that the doctor's added a new medication, you want to talk to them and say, I noticed that Dr. Brown, ordered for you to take this blood pressure medication and he changed your insulin. Tell me about your insurance. Do you have insurance to pay for that? What do you normally do? Because then you're going to want to talk to the care manager and have them make sure that they can implement something that can help them cover the cost of their medications. You want to look for physical disabilities in the elderly. So can they even get out to get their prescriptions? Do they have access to getting those prescriptions filled? Do they have access to ambulating in their home to find where their medications are? And then the big one we want to worry about is polypharmacy. So this is the use of many medications at the same time. This is often because they have multiple chronic diseases, but then when they're susceptible to interactions, which can cause an adverse effect in the patients. So drug therapy and normal aging that causes altered pharmacokinetics. There's dry or mucous membranes in the oral cavity, which will interfere with absorption. We have decreased circulation to the lower bowel. That's going to cause problems with distribution. We have decreased cardio efficiency. That's going to cause a problem with distribution. Remember, we don't have that good circulating blood volume. We said earlier we have less gastric acid. That's also going to affect the absorption. We have that reduced number of functioning nephrons by up to what, 50%, we said. That's going to cause a decrease in that glomerular filtration rate and reduce blood flow, which is going to affect the excretion. You can't excrete the drug, it's going to build up and become toxic in the body. And then overall, it's the declining organ function throughout the entire body that's going to require that close monitoring so that we can prevent drug toxicity. Medication problems when we think about non-compliance. So when I was in nursing school, something that they always told us is that patients are not just non-compliant because they want to be a butthead about it. There is always a reason why they're non-compliant. And it's true. I've noticed that. I can't ever think back to one patient that was non-compliant where there wasn't a particular reason why. Maybe it's just that they don't understand. Maybe they haven't been educated. Maybe they've had a misunderstanding. They didn't realize that their blood pressure was as bad as it was. Maybe they didn't listen when the doctor was educating and they didn't know they were supposed to take this blood pressure medicine and check their blood pressure. Maybe they can't afford it. I had a guy who came in the other day, his blood sugar in the emergency room was 785. He had to go up to the ICU and be put on an insulin drip. He was taking his regular insulin throughout the day, but he wasn't taking his long-acting insulin because he lost his insurance and he was using GoodRx. And even with GoodRx, the long-acting Levemir was $349 a month and he couldn't afford it. So these things happen to people. Maybe they have visual impairments and they can't see what they're taking. Maybe they think they're taking it. Maybe they're not. Maybe they're taking something else, or maybe they're taking too much of a certain medication. Polypharmacy, maybe they have so many that they're not organized anymore. They don't know which end is up. It's very easy for older people to get overwhelmed. Or maybe they have a physical disability, like we said, and they can't get to the pharmacy to get their medications, or they have trouble ambulating in the home and their son put them up on the top shelf and they can't reach them now. There's always a reason. And as providers and nurses, we want to make sure that we talk to our patients and find out why they're not being compliant so we can help them. So what are some nursing interventions that we can do to teach safe medication administration? So we want to make sure we're doing an accurate medication history. When that patient comes up from the emergency room and you're doing we call it an admission database, and we ask all these questions about our patients. One of them is a medication history. The people in the ED put all their medications in, or they carry over from a last visit. Maybe their medications changed from their last visit. That's why I want to go through each one. Mrs. Jones, I see you take Lipitor 40 milligrams every day. I also see that you take Celexa 20 milligrams each night. Is this true? And you want to go one by one and make sure you give the dose and the frequency. You also want to assess any barriers to compliance. So all the things we just talked about on the previous slide. Do they have access to the medication? Can they afford it? Do they know how to take it? Planning. We want to make sure we educate our patients about medications. I can't tell you how many times just in the hospital, I've had to give my patient a heparin injection. So when we bring patients into the hospital, we assess their risk of developing a blood clot. Depending on what other chronic illnesses they have, usually the emergency room physician does this, and they look at all kinds of stuff, like what medications they're on, what sicknesses they have, how old they are, and how many other chronic illnesses they have. Sometimes they don't need heparin. Sometimes they'll just get the SEDs that we put on the legs. Most people go on heparin because they're not moving around as much as they normally would. So we give them a prophylactic dose of a blood thinner. It is a very small injection, but it goes in the belly because that's where it's best absorbed. Well, patients freak out when you say, I have your heparin and it's an injection for your belly. And they'll say, no, I'm not taking it. But if you take the time to educate them and say, I know you're probably apprehensive about taking this, but it is a prophylactic dose, and it's really important that you take it because you're susceptible to getting a blood clot because you're not moving around as much. Well, what's a blood clot? Well, if you get a blood clot, it can travel through your body and it can go into your lungs or to your brain and you could die. Well, as soon as you say that, they're like, okay, I'll take it. They're usually still a little bit more apprehensive because they don't want it in their belly, but most people don't usually feel it. So it's really spending the time to educate the patient about their medications. Usually they are more compliant about it. And patients don't know what they're taking. I always tell their patients exactly what I'm giving them and why they're getting it. You have your blood pressure medicine. I have your metoprolol for your blood pressure. I have your amlodipine for your blood pressure, and I have your hydralazine for your blood pressure. Well, why do I have 3 things for my blood pressure? Well, because they all work differently. One's a beta blocker. One is a calcium channel blocker. They all work differently. So you need to know your medications. You need to be able to educate your patients. Recommend that they bring in a home medication record. I do this for my aunt. I do this for my uncle. I have a piece of paper in my computer that I keep, and I update it every time they go to the doctors if they change their medication. So if they go to the emergency room, I can pull out this piece of paper and say, this is their most current list of medications. Compare it to what you have in there, and let's change where we need to. So evaluation, we want to reassess them after we give them medications and make sure they're not having any crazy side effects. Implementation, so we can encourage our older adults to use a pill box and other type of organizer. Pill boxes are great. If they just take pills once a day, you can just get one for 5 or 7 days a week. If they have morning, evening, and afternoon, they have pill boxes for them. They also have them for morning and evening pills. Encourage loved ones to come over every Sunday and fill up their pill box so they make sure that they're taking the medications. Encourage those family members to come back during the week and check to make sure that those boxes are empty, so you know that the patient's taken the medication. You can get a calendar if you want. They want to write it on a calendar so they know which medications to take. Provide a schedule for administration. If you can just take something in the morning, it's better to take stuff in the morning. If they have a lot, do it between morning and night. Things get a little hairy when you're doing things morning, lunch, and dinner. So try and get them on a pretty consistent schedule. Do medication teaching safety with the family and their loved ones so they know the importance of why they are taking this medicine and why it's so important to take it at this time, or to take it with food, or to take it on an empty stomach. Use that medication calendar or diary to track, and then do not share medications with others. We talked about elder abuse with our patients, that this is something that we unfortunately see. So elder abuse is that can be an intentional or unintentional or failure to act by a caregiver or another person in a relationship involving an expectation of trust that causes or creates a risk of harm to older adults. So 10% of those adults age 60 and older who live in a community are abused. Older adults who have been physically abused present with injuries that are incompatible with older adults or caregivers' version of how they occurred. So if your patient comes in and they have a huge knot on their eye and they're in the emergency room, and I say, Mrs. Jones, what happened to your eye? And the son says, oh, she had a fall at home. And then you get upstairs later and maybe you forgot that, you know, the new nurse has her and she says, oh, Mrs. Jones, what happened to your eye? Well, my son pushed me down the steps. So inconsistencies in stories. A victim may deny abuse or choose not to report it because they are fearful or they're ashamed. Maybe they live with them and they don't want to end up in a nursing home. So they feel like it's better just to deal with what they're dealing with. Or they're worried that their loved one's going to retaliate against them. Or maybe they have dementia and they don't know. That's always a possibility too. So what is elder abuse? Elder abuse, it is physical abuse that can range from slapping, shoving, or actually beating. It's intentional failing to meet the physical, social, or emotional needs of that older person. Financial abuse can range from misuse of funds to embezzlement. And you will see this, patients, loved ones keep their We've seen it where loved ones have kept their mother or father alive and kept them a full code because they needed that Social Security check or their pension that comes in each month. You wouldn't think that those things happen, but they do more often than they should. And then when caretakers give the silent treatment or intimidate the individual by threatening them. And sometimes, especially if you're taking care of a loved one with dementia, it can be very wearing. And if that's what if they only have one child and they're the only child and they don't have any outlet? It's important for us to try and recognize opportunities for education and try and get that loved one some help caring for their mother or their father or whoever they're caring for, because it can be very emotional. It can be very stressful. It's hard. So like I said, it's not always intentional. Sometimes they don't know any better. They're not educated. They don't know certain things. So that's why it's always so important to not only help take care of the patient, but we want to educate those caregivers as well. All right.